So
Looking
again,
for it. Excuse me, right here.
Dr. David Huang is the director of electrophysiology at University of Rochester, and he has seen and he's seeing many long QT patients. Yes.
Thank you, Wojciech. What a great conference! What a great opportunity for us to interact with some of our patients on a different kind of format, and also some of the family members, and also a very distinguished panel here. Thank you for the opportunity to have a part of this and have a role of this. Um, uh, Both Dr. Vinocur and I, we are the more the clinicians, so we're trying to apply what the panel have learned and to apply to each and every one of these patients. So this is one sample patient that we actually saw fairly recently within the past year or so. And I'll go through some history and hopefully may be able to have some input from our panel here and go through some of the course of this particular patient as well. So this is a 49-year-old gentleman who actually is from more of the what we call the southern tier part of the New York State, a couple hours from here in Corning, New York. He has a history, very young, of reported WPW, a short circuit in the heart with a distinguished EKG pattern back in age 13. And at that time, he was placed on beta blocker medicine. And that medicine was stopped because he was felt to be doing well and did not have any other symptoms associated with this quote unquote WPW. However, he did have some of these seizure-like activities. And when he was younger, they were not taken very seriously. And then he had 2 more episodes of these seizure-like activities. Both of them occurred during the past year, so in 2018, 2019, and both episodes occurred during sleep. He underwent a fairly extensive first neurologic workup with CT scans, MRIs, and EEG, all of which came back normal. He was noted to have a slow heart rate on some of the heart monitors and EKGs, especially during sleep time in the night. And he does remember that when he was age of 9, he had these similar events during sleep. His mother reported these, and some of these events he was unable to be aroused, and took some time for him to wake up. So, excuse me. So when he was seen by the cardiologist in June down in Corning, New York, his QTC was reported to be long at 561 milliseconds. At the time, he was not on any QTC prolonging drugs and did not have any electrolyte abnormalities. And then because of these nocturnal awakenings and gasping and difficult arousals, he was actually referred for a sleep evaluation. And certainly, of course, that sleep study actually came back normal. He also underwent, because of these EKG changes, noted EKG changes, stress echocardiogram. And this is his electrocardiogram at rest right before the stress test. And would love to hear what the panels will describe and what the implications may be. I'm sorry that these are fax tracings to us, so they're not of the highest quality, but hopefully you can see some of the details here.
Oh, we'll be happy to hear. Obviously, we see here some QT prolongation, and on top of it, we see T waves, which are low amplitude in number of leads, as well as notched bifid, which, as we describe in 1995 paper, this may indicate long QT2 syndrome, but I will be happy to hear from other colleagues.
As usual, you're spot on, Wojciech. I mean, I guess if you were a betting person, you would see this ECG and you would put at least a 90 to 95% bet that there will be an LQT2 mutation.
Yeah, certainly that was our initial impression as well. We didn't have the EKG for review in June, but certainly the cardiologist did think that this was possible long QT as well. So he spoke with us after the stress test was done, and we had recommended beta blocker therapy starting with Nadolol at that time. But there's some interesting tracings here on the stress test. So during exercise, certainly his heart rate increased. And any further comments on the ECG here from our panelists, perhaps? And I'm going to keep moving on as well with the exercise as the patient exercise further.
I would like to comment
Yeah.
on the during very fast heart rate, like you are showing us, it's really difficult to judge well QT. Obviously, we can try to estimate it, but as we probably will discuss in a moment, probably recovery time will be better period to assess what's going on. But Mike, any comments from you?
No, the only thing that caught my attention, David, was when you were mentioning, I think in the story about the nocturnal agonal breathing or some breathing things. And in that first, the previous stress test trace, there's some tempting ST segment elevation in V1 and AVR that makes you start to wonder. And I've seen a handful of patients with this notch T-wave look, but then that ST pattern in V1 right there that brought us to the ultimate diagnosis of a unique Brugada syndrome.
Okay, interesting. Okay, and this is as the patient exercised further, we started to see a change in the EKG signal here on the far right side of the tracing, where the QRS signals actually become wider. And this was the EKG that was also obtained at this time. So of course, the cardiologist became concerned because this could be considered as a fast heart rhythm coming from the lower chamber of the heart because of the wider EKG signal here. We did hear about this. However, once we received a tracing and specifically saw this panel, I believe because of the characteristics of these premature beats here with the PVC, with the subsequent beat being a narrow and the following beat being wide, it was actually for me comforting to see that this was just a fast rhythm related with associated left bundle branch block with a little bit of conduction delay on the left side of the conduction system rather than a true ventricular tachycardia or any unusual abnormal short circuit like Maheim type of tachycardia. And here is the tracing for during recovery as the patient stopped exercise. Certainly, the QT intervals are very long. And we do see that broad-based T wave again, and perhaps some of the tracings may have some slight hints of notching as well. So he was referred to us and came up to us in August of 2019. And during our interview, he was noted to be leading a very healthy lifestyle, and very, very healthy lifestyle, someone who exercises rigorously. He runs 3 to 4 times a week. He also participates in martial arts and competes in martial arts. However, he denied any symptoms with exercise, did not have any pre-syncope or syncopal events. And then we had an updated ECG here. And this is a bit better quality tracing, but it does, I believe, show similar characteristics as what we saw during the resting phase of the exercise test. And by our calculation, I'm sorry, go ahead.
I was just going to say, this is such a great example of an LQT2 predictive one. And so I'm just curious, when you had that very first one, I think the timestamp would be a few months earlier. Did they do LQT genetic testing or not yet at that time?
They did not. They did not. So
I think that ties into what we were talking about with my lecture of how we still have a large community of practicing cardiologists and heart rhythm specialists who still have not brought genetic testing into their standard clinical practice.
Yeah, so just to be clear, this was from a general cardiology / internal medicine group. So they rely on referrals to electrophysiologists or arrhythmia specialists for more formal evaluation of these patients. At our evaluation, we did obtain an updated ECG. At the time, because of the ECG, we made the decision to up titrate a beta blocker dose. He was on 20 milligrams of Nadolol at the time. We, of course, submitted genetic testing, like what we've learned from Dr. Ackerman and everyone here. Recommended family screening. We discussed website crediblemeds.org, as we do with every patient with long QT or suspected long QT. This has a list of medications that people need to be aware of. And we also discussed about activity exercise restriction. Even though at the time we suspected it was long QT2, we still discussed about some activity limitations, especially with the type of rigorous exercise that he did. We talked about a few things as further workup. We were very concerned about his nocturnal symptoms. And because they did not occur very frequently, we talked about a possible insertable cardiac monitor, which is an implantable heart monitor, which is about the size of a USB stick or a matchstick that we may be able to implant under the skin to monitor a patient's heart rhythm over the long term. Along with that, we told him that if any potential cardiac arrhythmias are noted on the implantable monitor, the possibility of ICD protection may be considered. So not quite 10 days later, he agreed to the implantable heart monitor. So the monitor was implanted, and he went back to the southern tier to Corning, New York. Less than a week later, after the monitor was implanted, he decided to participate and to compete in a jiu-jitsu tournament. And while he was sparring with his opponent rolling on the floor, he actually became lightheaded and lost consciousness. Fortunately, many of the coaches and the officials there were EMT certified as well, and so he was found to be pulseless, and CPR was started. And when the EMS arrived, an AED was applied, and he was found to be in a fast ventricular arrhythmia, essentially cardiac arrest. And then a electrical shock was delivered by the AED, and he was successfully resuscitated. We had requested to get these tracings, but unfortunately we weren't able to, despite many attempts. So he was admitted to the outside hospital. Interrogation of this implantable heart monitor confirmed this ventricular tachycardia, this cardiac arrest, and it did have characteristics of torsade de pointe, the arrhythmia associated with long QT. And it was noted to be a rate of 350 to 375 beats per minute. I'm not sure how reliable that truly was. Nevertheless, a good information was that the whole episode lasted 7.5 minutes. For fortunately, the fire station, the firehouse was just right down the street, and EMS arrived very quickly. And he was successfully resuscitated very, very quickly. During the workup down there at the outside hospital, echocardiogram was obtained urgently. Ejection fraction or the heart function was noted to be preserved. They also obtained a cardiac MRI. They did show a small area of localized wall weakness in the right ventricle, but there was no any other evidence of another genetic disorder called ARVD or ARVC. Because of the events down in the outside hospital, he did undergo a dual chamber ICD placement. When we interviewed him afterwards, on retrospect, he said he was unsure that he might have forgotten Nadolol that day. And then later on, he actually did admit that he probably wasn't very consistent in his medications, even from the first time that he was prescribed Nadolol. So thoughts from our panel, perhaps. This, to be honest, this was a very scary experience, a scary case for us. I brought it to everybody here just to hear everyone's thoughts.
Do you have a genetic test result back?
We do. So genetic test result came back in October 2019, so after the event. And yes, of course, this was a KCNH2 mutation. Like the panel has suggested, this was associated with a long QT2 phenotype. It's a long QT2 mutation. And the mutation specified was actually in the pore region. So as Mike had mentioned already, this is the type of mutation that will lead to patients doing poorly. The further explanation on the mutation elaborated by Invite here is that this is KCNH2 protein. It's on exon 7, and it's located in the pore region, and it's a missense mutation with a defect in protein trafficking. So with the dominant negative effects. So these are all words that we look for that carry a worse prognosis for the patients with long QT2. Unfortunately, this information was not available, of course, to us during his initial clinic visit.
So the case which you, David, present brings a couple of important points. First of all, that this kind of clinical presentation may happen later in life, not only during adolescence or during early adulthood, but you have somebody who is about 50-year-old, and at that time, he develops the arrhythmia, which almost was fatal, if not this AED intervention. One could ask the question, because we today spoke so much about females being at high risk, what would be the reason that this particular person all of a sudden at the age of 50 develops the risk of arrhythmic events? One could raise the question, is this kind of activity, like you describe, physical activity and strong exercise contributing to increased risk like it does in arrhythmogenic right ventricular cardiomyopathy? Are there other factors, maybe underlying additional coronary disease, since you indicated some weakness, so-called in left ventricular or in heart function. So this might be interesting question why this man in his about 50s developed this not at his 20s. Any comments?
But David, maybe this patient was symptomatic from childhood, as far as I understand, right? He had seizures. So this patient,
Right, he has some nocturnal events.
yeah,
Correct.
may have expressed LQTS in childhood, and that was missed. And if we want to summarize all the risk factors and possibly to identify whether the patient should have gotten ICD earlier. So the patient had a poor mutation. Yeah, okay. You want to go over the risk factor that this patient had? Because
Yeah. So this patient carries all the high risk factors. So his QTC was, to me, was a very dominant and very early factor that we knew about. His QTC was consistently greater than 500 milliseconds, and in fact, in a couple of the tracings was greater than 550 milliseconds. He has a poor mutation, poor loop mutation. So we know that's associated with a worse outcome. Even though it's not quite syncope, these nocturnal events can be perceived as equivalent to syncope, perhaps, because we do know that patients with long QT2, many of their events tend to occur more at rest than with exercise. So his risks, once we got to know all his characteristics of his long QT, certainly he's at least high risk, if not in a very high risk area.
and he was on Nadolol already.
He was on Nadolol. Initially, when the cardiologist saw him, and after speaking with us, he was placed on 20, and then we put him on, we upped him to 40. On retrospect, it's not that clear if he was completely compliant with his medical therapy.
Yeah, I think, David, this is a great case that shows us several things. One, I think it's so disappointing when we still see such a profound delay in correct diagnosis. You know, when symptoms that were there in childhood, adolescence that never got bubbled up to the right kind of cardiologist, you know, the delay in getting this person to you to where, you know, he almost gets stuck with the defibrillator. His cardiac arrest should have never happened, right? We shouldn't have a loop recorder recording death when he clearly had LQT2. We didn't need the genetic test to know he had LQT2. He's LQT2 with a QTC of 550. Nadolol of 20 milligrams is not therapy in a man with that kind of a risk category. 40 of Nadolol in a man is not therapy. So we really never got a chance to get him onto non-ICD true therapy. Now, it sounds like his medication adherence profile may not have let you, got him to Nadolol plus mixilotine or denervation, but you really never were given the opportunity to see if you could get conventional therapies to be pleasing to you because of the hand that you were dealt. And I just think some way we have to shorten the time interval from first symptom of concern to discovery and rendering of the correct diagnosis.
Yeah, it just so happened that the events took place very, very quickly right after we saw him. It also speaks about compliance as well, because we did talk to him about his exercises that the event actually took place during a competition as well. So compliance is very, very important for, we do tell our patients with long QT that they really should regard beta blocker as a life-saving medication, that they should not be missing their medication at all. So
let me ask Jeff, as we discuss this case, looks like that the seizures were 40 years ago, about the age of 10, yes. So obviously our knowledge at that time of long QT was different than it is now, and how widespread knowledge was. How would you approach a 9 or 10-year-old who comes to you with history of seizures in such case?
So, I mean, obviously, 40 years ago, it's hard to criticize. I think we are starting to make some headway with the neurologists that, you know, one ECG should be done, particularly with sort of the, you know, kind of exercise emotional sort of seizures. And also that they should be looking at the rhythm strip that they record whenever they get a brainwave tracing. Because I certainly have a patient who is admitted for long-term brainwave monitoring, and you know, after 24 hours in the hospital, they download it, and you know, there's a minute-long episode of ventricular tachycardia that was all long QT syndrome, and as soon as we gave him appropriate therapy, his seizures stopped. So I mean, I think, you know, I think I agree with Mike ultimately, right? Like the moment that someone saw a QT over 500, this became an emergency. And the time from there to appropriate evaluation, it should have been shorter. You know, up till then, you know, there are things that could be better, but it's harder to debug that. You know, but in my mind, this is like, you know, getting a MRI that has a brain tumor on it and it taking a year for it to, you know, cycle through the workflow.
And I think that's the critical thing, right, is to sensitize people that, you know, while most of long QT syndrome, we can take our sweet time at, because most of long QT syndrome is pedestrian, uneventful, low risk, but we do have what ought to be the equivalent of our 5-star alarm or whatever that term is. And I can tell you what we do in our practice. When we have a newly discovered person like this with a QTC of 500 that we predicted LQT2 pre-genetically, and then we uncover that there were passable seizures in his past, he would have gotten a life vest put on him while we were optimizing his treatment program. And that does two things. One, that conveys that this is a high-risk situation for which we do not have satisfactory treatment in place. Yes, he's 50, but he's already had his pre-sudden cardiac arrest escapes. And to help convey whether that or not that would have helped this particular gentleman's, you know, medication adherence, you know, we would let all of our long QT patients return to athletes, but not at that stage. They do not get a return to their sport until I'm pleased with their treatment program. And clearly we weren't pleased with this person's treatment program. And so I think there's not too many patients that you encounter that you need to put them in the, you know, the emergency urgency penalty box. But this story would definitely be one of those that would have.
That's a great case. I wanted to take a second to bring Mike's question, which showed up a moment ago. And this question came up recently in some conference calls we had with Dr. Ackerman, which was orchestrated by Dr. Elizabeth Kaufman from Cleveland. The topic relates to what extent during delivery, when mother has long QT, this should be supported by additional requirement for defibrillator or other precaution. Mike, what are your recommendations for young mothers with long QT syndrome prior to their delivery, and how do you discuss it with gynecology colleagues?
Yeah, I think that's a great one, because I think we've gotten wrong messages put out there to the obstetrician community and to the families that this labor and delivery setting is a spooky setting of risk, and it's not. So I personally do not like calling these mothers and their babies high-risk pregnancies. I do not like that designation. I think it's erroneous. I do not think these are high-risk pregnancies. It is not a high-risk delivery. And I think the consequence of that designation is we see far too many long QT C-section deliveries because of the long QT diagnosis when the mother and the baby should deliver under obstetrical criteria. It should be made to be, we see the babies getting snatched away from their mothers and being brought, swiftly to the step down, level 2 nursery, as opposed to letting that critical mom-baby bonding happen. And so I personally like to reassure the obstetrician. We develop a delivery plan with them. It's mainly to get them more comfortable that this is not a high-risk setting, and that the baby can be delivered vaginally if it's obstetrically indicated, that there just needs to be awareness. I can tell you that in my entire 20 years, I don't think we've ever had an AED resuscitation occur during labor and delivery of a single LQT mother. So it's hard to call this a high-risk pregnancy when the, event rate is really low. And I think that's where you and I, Wojciech, have been trying to get those people who are calling these high-risk pregnancies to say, where's the beef? Show me the evidence as to why we should be calling these high-risk pregnancies. And if not, we should be helping the obstetrical community get more comfortable and get more relaxed about these so that they can be a wonderful delivery experience for these families. I've heard of just absolute horror stories of what the healthcare system has done to the labor and delivery experience of these long QT families.
That's a very good comment. Thank you, Mike. Any other comments from panelists? If not, we will ask Dr. Vinocur to share his thoughts. David, if you could stop sharing, please.
Hi, everyone. I have a couple of short cases, so I'm hoping, sorry, just getting the screen share. I'm hoping to sort of get through one case where there's a few interesting points and let people comment for a couple minutes, and then do a second one. And I don't know if we'll have time for a third, but
it's very good.
Okay, so the first one is a pre-reproductive consult that I really enjoy doing these. I don't get to do enough of them, I think, because there's a lot of misconceptions, as Dr. Ackerman was just saying. But I had one that did happen of a woman who had gotten married and was thinking about having children. So her story was that she had come to medical attention as a teenager when she fainted at soccer. She, of course, got an ECG, and as you see, the QT is long and the T waves are somewhat abnormal. She had genetic testing that showed unambiguous long QT syndrome type 1. This being some years back, she was started on beta blocker. She was pulled permanently from sports that had been important to her. She had a defibrillator implanted. She then had very poor healing with a lot of sort of emotional consequence to that. Had steroid injections in the scar, had plastic surgery revision of the scar, then had a lead malfunction that had to be extracted and a new lead put in. And in all of this time, she has had no further fainting, no shocks, and she had a single 3 to 4 second episode of fast VT recorded in her defibrillator on quite a low dose, really, of beta blocker. So, of course, the husband didn't have nearly the experience that the wife did. And so we talked through long QT syndrome. We reviewed the 50% chance of the gene being passed, and that the child might be having a more or less severe version of long QT syndrome. But because long QT1 is so nicely responsive to treatment, it's very unlikely that the child will ever faint, let alone have a cardiac arrest, very unlikely to have broad restriction from sports, and very unlikely to need a defibrillator. So things went as they do, and sometime later I heard from them that the baby was born and had a QT of 50. And so of course the newborn nursery wants to know what they should do. Does the baby have long QT syndrome? Certainly it's suspicious, although early after birth, the QTs run long. And so I don't know that I was quite ready to say for sure. We talked about whether we should start beta blocker at that point, although there's the issues of low blood sugars with beta blocker in babies. And actually we sat tight and the QT rapidly came down to 460. And we waited for genetic testing, which did indeed come back positive. And at that point, we diagnosed long QT syndrome. We started beta blocker and expected things would be a very long, boring run for the next, probably 100 years. So I don't know what people want to say about the first one from the panel.
First of all, the indication for an ICD in the woman was borderline, right? Do you have the indication for the ICD? What was it? Because she actually was not symptomatic on beta blockers.
So she didn't have a chance to be symptomatic or not on beta blocker. She had a QT of 500 and symptoms and was implanted.
So she only got the complications of the ICD.
Correct.
As Mike probably will comment, we all know, especially now after 20 years of research, that LQT1 patients are very effectively treated with beta blockers if they are obviously adhering to the treatment. So one obviously could argue about this decision made at that time. But speaking back about your ECG of the child, let us stress that what you pointed out, Jeff, that before practically 3 weeks or 1 month after birth, many of those ECGs in newborns will show some QT prolongation because there is some still ongoing maturity of the heart outside womb. So as it was documented in some studies from Italy, and I believe Dr. Ackerman also wrote on that, one should be cautious, and as you, Jeff, said, with the immediate first day, second day evaluation. We have a number of ECGs in our registry which were submitted to us on day 1, 2, or 3, which subsequently months later, 3 months later, showed much shorter QT. So I would welcome the comments again on that from Mike and maybe further from Jeff.
Yeah, I mean, I think that's the beauty of this case in that we never start the beta blocker on day 1, period. We always wait for the second day, and then depending on that, we make a pre-genetic test result decision about initiating beta blocker therapy. And here's an example where a lot of places, they would have started the person on the beta blocker, and then the next day or a couple days later saw 460, and then that's where the language has come about of, look how dramatically the beta blocker shortened the QT interval. When the beta blocker had nothing to do with the QT improvement, time did. And this one you could predict for sure that this was going to be an LQT1 positive baby on this ECG because it's so far outside of the newborn normal, but it just shows you how much newborn QT transition there is that can occur. And so a 550 QTC baby and a 460 QTC baby, based upon the past where we took a person's longest QT interval ever as their risk marker ECG, just shows you that that longest ever ECG isn't the best way to do it any longer, because we would have had a 550 forecast based on day 1, a 460 millisecond forecast based on day 2. And so this is a great one. It's great to see that Dr. Vinocur dragged his feet and didn't start the beta blocker on this first one, because it just shows you what we all know can happen. I don't think he was expecting it to be LQT1 negative with the result, because this one just tells you it looks like LQT1. It doesn't look like a long QT baby, but it normalized impressively. And I think the fact is that a person's longest QT interval ever in their life, short of getting a drug that makes it longer, is their first ever ECG. And that's almost invariably the case, that your first ECG is going to capture your longest QTC, especially if it's your newborn ECG.
Thank
What's
you.
your
I
thoughts
think
about
David has a comment.
the
David?
early infant
Yeah.
timing of beta blocker initiation and hypoglycemia risk?
Yeah, I don't think the hypoglycemia risk has anything to do with the newborn period. So we published the hypoglycemia experience in beta blocker. It is much higher with long QT kids than in, as Jeff knows, your SVT babies who you start on beta blocker, and the dermatology babies with whatever that,
Hemangioma.
yeah, the hemangioma that they start on beta blockers, they basically never see hypoglycemia. You may have never seen hypoglycemia in any of your SVT treated babies, but you do see it in long QT syndrome, which has to do with the fact that those LQT1 and LQT2 babies, those potassium channels have some level of insulin secretion regulation. They contribute to it weakly. And that plus the beta blocker is probably what creates the hypoglycemia risk. But that risk is still only about 5% of all of our treated children under the age of 5. So I think it's still a pretty low risk. I don't think it matters whether it's the first week of life or the first year of life for that. So we just counsel the family about not giving the nighttime beta blocker if they're not taking their caloric nutrition that evening for whatever reason, because that's almost always the scenario when it happens. They didn't take their evening nourishment. They then woke up in the morning already a bit glucose challenged, and then the beta blocker tipped it over the edge. So I would be fine starting it on day 1, day 2, day 5, if I thought the baby had, long QT. Now you have an interesting question with a QTC of 460. If this was a baby girl, I have many baby girls with a QTC of 460 where we have still not started their beta blocker. Even though the guidelines call for universal beta blocker, we have continued with intentional non-treatment as we watch that baby girl mature. And we have several of them where we've never started the beta blocker now, when they are found in that lowest risk category and are only doing the QT preventative measures.
Excellent.
Thank you, David.
Yeah, the other, we have 2 patients here, of course, the mother as well. And I don't remember if Jeff, you said the ICD once it was extracted, whether another one was implanted. So unfortunately, we do see some of these patients, and perhaps in some ways similar to some patients who come to us with a long QT diagnosis. Some of the hardest things we have to do is to undiagnose the long QT syndrome in some of these patients. Another hard thing to do is many of them may have had these devices implanted for borderline indications. And if they've experienced complication, especially if they've experienced complication from it, and she's still quite young, she is likely to experience further complication. I think discussion should be made about explanting the ICD for good.
Agreed.
Because these could become very serious complications that could have long-term implications in terms of infection issues, heart valve issues, let alone the cosmetic and emotional issues associated with inappropriate shocks.
All right. Let me try this.
Yes, please.
So this is a 16-year-old woman who had presented to her pediatrician with lightheadedness. She had started working in the kitchen at a fast food restaurant, standing in one place. Of course, it's hot. And the symptom was that she would sometimes get lightheaded, dizzy, warm, nauseated, and feel her heart rate fluctuating. This story prompted an ECG that is unmistakably abnormal, although I am 100% sure that her symptoms were not arrhythmia related. So I just saw this come through in the pile with a QT of 490, called to get it sorted out. Brought her in, we talked about things, we had several ECGs over the next weeks, all with QTs in the 470 to 500 millisecond range. And so I was quite sure already that she was going to have long QT syndrome. We sent genetic testing and we got this fairly uncommon version of a KCNH2 variant, but clearly is going to disrupt the protein function. And so we diagnosed her with long QT syndrome type 2. And at this point with asymptomatic long QT2, we were planning to do beta blocker trigger avoidance and, cautiously optimistic that there would be not much to come of it. So we started with Nadolol. She had severe hair loss with Nadolol and would not take it any longer. We switched her to long-acting propranolol twice a day, and she had hair thinning with that, but said it was manageable. She had gotten, I think we had started with 80 twice a day, and had given her a plan to start working up on the dose, but actually that didn't happen. One of my questions was, what's a realistic goal for adults for propranolol? And then not too long later, we have an urgent visit because she had fainted while walking down the steps at school, fell down a few steps, was not injured, woke up immediately, had not missed any doses of beta blocker, had not had any illness, and had not heard any loud noises to be a trigger. So, here we are at this visit trying to decide if this fainting episode was related to an arrhythmia. And if it was, does she then need a defibrillator or a denervation surgery? Being an adult woman with long QT2, who's now fainted despite beta blocker and a QT at this point of 500. I have to admit I wasn't completely sure what to make of the fainting, but thought it seemed like reasonable to try to escalate her treatment in some way. And fortunately, this was not that long ago, and we do have a little bit of data now about the role for mexiletine in patients with long QT2. And so I went ahead and started her on mexiletine and also got her to work up on the propranolol like we had planned to the previous time. So after a little bit, we have her on 120 twice a day of propranolol, 200 twice a day of mexiletine, and she has a QT that is 415 milliseconds. And so I felt very happy, and we've done very well ever since.
That's a great case, Jeff. I
Very
mean,
nice.
a couple of things with respect to the mexiletine is, unless you've checked her CYP2D6 genotype to know whether she's a standard metabolizer or an ultra rapid metabolizer, mexiletine pharmacokinetically is a 3 times a day drug. The timing of this ECG suggests that she had a good effect, but I always, with the mexiletine, I think it's really important for us to check trough levels to know the CYP2D6 genotype so that I know if I can use that genotype to my advantage to be able to get by with just twice a day dosing. So that's just something to look into, but at least, if the mexiletine was taken in the morning and this ECG was taken 2 hours, 3 hours after her morning dose, then you're really getting a peak McSillatine ECG effect, and you may not be knowing or maybe getting a little bit tricked by what the trough level of the McSillatine effect might be, especially with spacing out the dosing. But I think if she can tolerate this combination therapy, you know, you've helped dodge a bullet of having to prematurely intensifying her treatment to devices by using these two medications well.
Yeah, interesting case. I have a question. So this patient, you are not clear about the correlation between symptoms and the trigger could be arrhythmic, non-arrhythmic. What about the role of, in this patient, of an ICM, ILR? What do you think about that? Trying to identify if she doesn't have another episode of lightheadedness, which could be, then you gotta know.
It's a very interesting question. You know, since we've gotten the miniature loop recorders, you know, I think we're still finding our way as to what the utility is. You know, I felt pretty good that if this was a rhythmic syncope, we've now reduced her risk so much that we would get 3 years of monitoring with nothing on it. And if it wasn't, then we would get 3 years of monitoring with nothing on it. And so this one didn't strike me as particularly useful. I definitely have had other patients, either because of questionable symptoms or because of a risk profile that was very close to the threshold of some other intervention, like a defibrillator, that I've gone ahead and used an implantable loop recorder as a way to sort out the symptoms or to screen for episodes that the patient might not realize, especially patients who might have arrhythmia at nighttime.
Thanks, good point.
Do you think we can get one more in?
Yes, please.
Okay. So the third one is a 4-year-old who presented with a cardiac arrest in the setting of mild excitement. The initial recordings are the telemetry from the intensive care unit while he's having total body cooling. And, you know, there's a few different strips with varying amounts of abnormal rhythm mixed in. And certainly by the bottom of the screen, you see long periods of very rapid and very abnormal rhythm. I have another screen full of these coming in a second. I picked the worst strips. It's not all of this back to back. These things are scattered on and off through the, you know, through periods that look a little bit better. Needless to say, this was very concerning to everyone involved, and he was given intravenous beta blocker, and the rhythm quieted down substantially. And fortunately, he recovered well from his cardiac arrest. And when the dust had settled, he'd had a number of ECGs. I picked some for you at different heart rates. And, you know, I think more often than not, the QT, it looks pretty normal, although sometimes it is somewhat long.
I think a key there is a really good one there, Jeff, is in lead 2, that low amplitude flattening of the top is how children show their LQT2. So if it wouldn't surprise me if this one ends up having another LQT2, since you're on a string of LQT2 examples.
I suppose.
But this lead 2 is a pretty good pre-pubertal lead. And I think of Wojciech, Arthur Moss was probably one of the first ones to show this about the limb lead 2 and not being necessarily the classic V4 notch, but just this really low amplitude. And you can almost make out a notch. I call it the flat top T wave in lead 2.
Yes, well, lead 2 definitely is very diagnostic, but let's hear from Jeff.
Yes. So, well, this is before my time, but I think everyone asked the right questions. It was a structurally normal heart with a cardiac arrest and very ugly arrhythmias. And so he was going to get a defibrillator and beta blocker and genetic testing. So he gets his defibrillator. Genetic testing actually took quite some time because of it's with insurance in the era that it was. But he did ultimately have a long QT panel that came back with this SCN5A variant that at the time was called a class 2 variant. And I think, of course, now the question comes up whether this is long QT type 3.
So Jeff, if you could come back to first ECG, I didn't have chance to comment on it for a second, your first slide. So
Sure.
I wanted to point out that the first line of this ECG you are showing now is exactly what we sometimes saw in LQT3. And I was about to comment on this shape of the T wave, because in number of LQT3 patients, this kind of like little bit notched T wave of this kind of asymmetric morphology with little bit faster downsloping, as you see, we saw in numerous LQT3. I didn't have chance to react immediately, but I saw it at first. And my first reaction after I saw it, it will be LQT3, honestly. So I'm just pointing out this one tracing, although I didn't see that much in those lead 2 tracing, the same pattern. You know.
Yep. So this is about when I'm coming into the picture. And at this point, I said it doesn't really all fit together to have a adrenaline-driven arrest to think that it might be long QT3. And ultimately, we ended up sort of sitting tight. We tried to get the family screened, although the parents are not still in touch and so on. And years go by, and he did very well. He's on beta blocker. He has no defibrillator shocks. He gets old enough to start doing stress tests, and we do stress tests, and they look, I think, somewhat more like CPVT, which is a related similar condition. But there are some bits that look like long QT syndrome. The original testing had not covered CPVT, and so we went back and got that done, and that was negative. And so we sat tight again for some years by. And then over the past few years, there start to become these publications about this new set of genes called calmodulin, and the multiple manifestations that they can have. And so we sent a modern updated set of genetic testing, and he comes back with a calmodulin pathogenic variant. And the other interesting thing I thought was that in the intervening years, that SCN5A variant that we thought, might be something, is now so unimpressive that they don't mention it on the report. That was that one.
Thank you. I think that this will be our last case. Mike, would you like to make any comment on this calmodulin mutation?
No, I think it shows you that when you have somebody thinking long QT and thinking CPVT and thinking the T wave looks like LQT2 and thinking it might look like LQT3, put your money on calmodulinopathy when you're starting to think like that in a child. So obviously we've learned a lot about the calmodulinopathy since the first CALM1 gene 1 and 2 were discovered by Peter Schwartz and Leah Crotty and Al George, and then we added the CALM3 gene. And this is a very challenging, rare set of long QT, if you will. So I think it's calmodulin long QT if the phenotype is long QT. It's calmodulin CPVT if the phenotype is more CPVT-like, and they need to be very well beta blocked. And this is the one subset that we remain, I would say, fairly ICD aggressive overall.